this section, we'll discuss applied statistics. Statistics are often used in diagnostic testing. The problem is that quantitative tests do not perfectly separate diseased from healthy individuals. There's always some overlap. So the question really is, how do we quantitatively define a positive test? What is the optimal cutoff? Example, at what fasting blood glucose level should we diagnose an individual with diabetes? Necessarily, we're always going to include people in the wrong diagnostic category for whatever diagnostic threshold we choose. The question is, how do we choose these thresholds, and how do we deal with the trade-offs? So here's a more graphical representation of the problem. When we have a particular parameter or value that we're looking at, we know that the diseased population will have some distribution of that measured parameter, and the normal population will have some distribution of that parameter, and there will almost always be some overlap in that parameter. For example, glucose. We know that patients with diabetes have higher glucoses on average than patients without diabetes, but if one were to look at the distribution of all diabetic individuals and look at their fasting blood glucose levels, you'll find there'll be some spread of those values, let's say from 100 to 150. If you did the same thing for normal people, you'll also find a spread of those values, and that may range from, let's say, 75 to 125. Well, there will be some overlap in those values. So when somebody obtains a value of 125, how do you decide? Is this a person who has diabetes or not? Well, if you make that cutoff value higher, let's say you make the cutoff of 140, well, if that would be the case, then you have a much greater chance of being correct if you state that somebody has diabetes, if they have a blood glucose level above 140, but you may miss many of those diabetic patients who have blood glucose levels below that. So these types of trade-offs are commonly made when deciding what the threshold value is for deciding whether or not a diagnostic test is positive or negative. Often, when characterizing a diagnostic test, it's useful to describe all the various possibilities in a 2x2 table as shown here. The way the table is laid out here, the actual presence or absence of a disease is listed in the columns, whereas the positivity or negativity of the test is listed in the rows, such that if a test is positive in the setting of a disease, one will have a true positive value that's on the top left. However, if a test is positive in the absence of disease, that would be a false positive value shown on the top right. If a patient has a disease, however, the test is negative, that would be a false negative value shown on the bottom left. Whereas a patient, if they don't have the disease and the test is also negative, that would be a true negative shown on the bottom right. Clearly, ideally, for a diagnostic test, we want to maximize the true positives, maximize the true negatives, and minimize the false positives and minimize the false negatives. In the next slide, we show one way of deciding what a cutoff value is. Let's say we have two populations with partial overlap, and the dotted blue line corresponds to our diagnostic threshold for calling something a positive test or a negative test. Well, if we choose this threshold, what do we know, or what do we have to accept? We know that a certain population of people will test positively, and those will be true positives, but a certain population of people will test positively who don't have the disease, and those will be called false positives. Conversely, a certain population of a certain percentage of the population which is normal will have a negative test. These will be called our true negatives, and a certain percentage of the diseased population will also have a test value below this threshold, and these will be false negatives. Now, this is only one way of choosing a cutoff. We can choose a cutoff which is higher or lower. So how do we optimize the cutoff? Well, we want to set the cutoff value of the test such that we optimally minimize the number of false positives and false negatives. And we do this by trying to maximize the sensitivity and the specificity of a test. So what do we mean by sensitivity and specificity? Sensitivity measures the ability of a test to accurately diagnose those who have the disease. Maximizing sensitivity minimizes false negatives. In other words, sensitivity is positive when a subject actually has a disease. It is defined as the fraction of individuals with the disease who had a positive test. In other words, it is equal to the true positives over the sum of all the true positives and the false negatives. Graphically, often it's helpful to look at these values in a 2x2 table setting. Again, with the disease state listed in the columns and the test result listed in the rows. In this format, the sensitivity will be equal to the top left square, divided by the total number in the first column, or the true positives divided by all the people who have the disease. So given the hypothetical data shown in the next slide, we can compute the sensitivity of this test. So in this case, we have 100 people who have the disease, 90 of which tested positive and 10% tested negative. We also have 100 people without the disease, 90 of which tested negative and 10 of which tested positive. So given these data, we can compute the sensitivity of the test. It's simply the number of people who had a true positive divided by all the people who had the disease, in this case 90 over 100, giving us a sensitivity of 0.9 or 90%. Specificity measures the ability of a test to accurately diagnose those who do not have the disease. Maximizing specificity means minimizing false positives. Specificity is the fraction of individuals without the disease who had a negative test. In other words, specificity is negative in health. Mathematically, this is expressed as the true negatives over all the people who do not have the disease, the true negatives plus the false positives. Going back to our 2x2 table with disease in the columns and test results in the rows, one can compute the specificity by taking the true negatives, the bottom right-hand corner, and dividing that by all the people who do not have the disease. Taking our hypothetical data as before, this would be computed by dividing 90, which is the number of people who do not have the disease and also tested negative, and dividing that by the number of people without the disease. Therefore, we have 90 over 100, or 0.9, or a specificity of 90%. Practice question. You're part of a research team developing a rapid screening test for swine flu. Which of the following would you most like to have in your screening test? A. High specificity with low sensitivity. B. High sensitivity with low specificity. C. High specificity with high sensitivity. D. Low sensitivity with low specificity. E. Sensitivity and specificity do not matter in this case. Well, there are a couple important things to remember when answering this question. Whenever you're looking for a screening test, the important thing is to have a highly sensitive test, because you're trying to capture a large population that has some risk for a particular disease. So screening tests tend to be those that have high amounts of sensitivity. The other important thing to recognize is that sensitivity and specificity are always traded off. That is, in order to achieve high sensitivity, one can achieve that by lowering the specificity and vice versa. So in this particular case, we're looking for a screening test. So we know we need to have a test that has high sensitivity. In this case, the only answer that gives us a possibility of having high sensitivity would be B or potentially C. But recall that high specificity of a test necessarily comes at the cost of sensitivity. So screening tests are those that have the highest sensitivity possible, and that's only possible by lowering specificity. So the correct answer here for a screening test would be B, high sensitivity and low specificity. Practice question. Now that you've discovered the patients that have swine flu, you decide you want to try a new experimental antiviral therapy. This therapy has been shown to eradicate the virus in less than 24 hours, but there is a risk of developing severe anaphylactic shock. Which of the following will be most beneficial in selecting which patients to treat with this new therapy? A. High specificity, low sensitivity. B, high sensitivity, low specificity, C, high specificity, low sensitivity, D, low sensitivity, low specificity, or E, sensitivity and specificity do not matter in this case. Well, here we have a different kind of question than the previous question. We've already screened patients with our very high sensitivity, low specificity test in terms of those who may be at very high risk for swine flu. However, we now have a potentially toxic experimental therapy. We want to minimize the likelihood of exposing this toxic experimental therapy to patients who don't actually have the disease. Therefore, we want to achieve a very, very high specificity such that we have a very, very small number of false positives. So we want a very high specificity test to only expose patients who have the disease to this potentially toxic therapy. So the answer here that has high specificity, or the answers, would be A and C. But similarly to the previous question, high specificity comes at the cost of low sensitivity. So if a test has high sensitivity, the only one can make that test even more specific by lowering its sensitivity. So the correct answer here would be A. We want a high specificity, low sensitivity test for this particular purpose. Practice question. A new screening test for HIV infection is being tested using an antibody against a newly discovered viral envelope protein. If this new test causes the cutoff to move from line X to line B, the sensitivity of the test will do which of the following? Increases, decreases, stays the same, equals the specificity, equals the negative predictive value. In shifting the diagnostic threshold from X to B, one is raising the threshold by which one would call a test result positive. By doing that, you are more likely to miss real positives in the population. Therefore, you are decreasing the sensitivity of this test. So the answer here would be B. By the way, you are also increasing the specificity of the test because you're making it less likely that you would make a determination that somebody has the disease when they in fact do not. What about a situation as follows? Let's say we have hypothetical data where 100 people have the disease and 10,000 people do not. So we're talking about a disease which is relatively rare. If we have 90% specificity and 90% sensitivity, the data will look like the following. With 100 people who have the disease, we would have 90 true positives. We would have 10 people who do have the disease who tested negative. If we have 10,000 people without the disease with 90% specificity, we would have 9,000 true negatives, but 1,000 people who do not have the disease who test positively. What does this imply about a positive test? Let's say we have a random person who walks through the door who has a positive test. What does this mean? Do they have the disease or not? How much faith can we have in that value? Well, the utility of a test will depend upon the prevalence of the corresponding disease in the population tested. And the way that we make this determination is by looking at the positive predictive value of a test, and as we'll learn, the negative predictive value of a test. The positive predictive value, or PPV, measures the ability of a positive test to distinguish between those who have the disease and those who don't. PPV is a fraction of individuals with a positive test who have the disease. In other words, should I believe a positive test? This actually, clinically, is a much more useful value than the sensitivity or specificity, because in clinical medicine, these are the questions that we're faced with. We get positive and negative tests all the time. How much faith should we put in these test results? In this case, the PPV is going to equal the number of true positives divided by all the positive test results that we obtained. Going back to our 2x2 table, where we have disease in the columns and test results in the rows, the positive predictive value will be the true positives, so the upper left square, divided by all the positives, meaning all the positive results in the upper row. Well, if we have a prevalence of the disease which is approximately 50%, that is an equal number of people who have the disease and those who don't, we can compute the positive predictive value here as being 90, meaning the number of true positives, divided by the total of positive test results, in this case 100. So the PPV, or the positive predictive value, is 0.9, or 90%. What about a disease that has low prevalence? If we go back to the hypothetical data described earlier of a disease of low prevalence and compute the positive predictive value, we find that the PPV is now 90 divided by all of the positives, which is 1090, and we have a PPV of 0.08, or 8%. So our test characteristics have not changed. We still have a 90% sensitive and a 90% specific test, but our PPV has dropped dramatically because of the low prevalence of the disease. This means that if we randomly applied this test to an individual in our clinic and we got a positive result, there's only an 8% chance that this patient actually has the disease. This is an extremely important concept in interpreting test results, because the test results will depend very greatly on the prevalence of that disease in the population. Negative predictive value. The negative predictive value, or NPV, measures the ability of a negative test to distinguish between those with the disease and those without. The NPV is the fraction of individuals with a negative test who do not have the disease. In other words, given a negative test result, should I believe it? We compute this as the true negatives divided by all the negatives. So this is an exactly analogous situation as we discussed with the positive predictive value. Faced with a negative test result, how much faith do we put in those data? Going back to our 2x2 table, we compute the NPV by dividing the true negatives, the bottom right of this table, by all the negatives, the bottom row of this table. We're looking at a situation where we have equal prevalence, or a 50% prevalence rate of a particular disease. The NPV is 90 divided by 90 being all the true negatives, divided by all the negatives, which is 100, giving us an NPV of 0.9, or 90%. So if we had a negative test result in a patient, we can feel 90% confident that they don't have the disease. What about the situation when the disease has a low prevalence? Now if we put the numbers through, we have a true negative number of 9,000 divided by all the negatives, which is 9,010. We now have an NPV of 0.99, which means we can feel 99% confident that the patient does not have the disease. So what is this really telling us? This means that the background rates of disease make an enormous difference in interpretation of test results. Most patients who walk through the door already have some probability of having the disease. The test result simply increases or decreases the probability of that disease being present. So important general rules is that the positive predictive value increases as the prevalence of the disease increases. The negative predictive value increases as the prevalence of the disease decreases. This is the reason why we don't simply screen entire populations for disease. You can imagine the very large numbers of false positives that one would get if you screened a large population for a rare disease. Practice question. A 16-year-old adolescent girl is brought to the physician's office by her mother. The mother is extremely concerned because her daughter has reported that she felt a lump in her breast yesterday morning. There is no family history of breast or ovarian cancer. The physician performs a fine needle biopsy at the mother's insistence. The results come back negative, and the doctor phones the mother with the results. The mother asks, "What are the chances that my daughter really doesn't have breast cancer?" The physician replies that they are low in this case because the FNA, or the fine needle aspiration, has a high, answer A, specificity, answer B, sensitivity, answer C, positive predictive value, D, negative predictive value, or E, accuracy. Well, recall, what do we need to know to interpret the results of a test? We need to know something about what the background rate of disease is. So we're given a situation where we have a young woman who has a lump in her breast. The likelihood of her having breast cancer based on background rates and risk factors is extremely low. There's no family history, and she has a test result which we're now interpreting. So in the setting of a very low background rate and a negative test, if the physician interprets this as being low, we can extrapolate that the reason that he has this confidence is because of the negative predictive value of the test. The negative predictive value is driving our interpretation of this test, primarily because of the low background rate of disease. And so for that reason, the answer is D, negative predictive value. Practice question. A new screening test has been developed for detecting sickle cell trait in a given population. It has a specificity of 90% and a sensitivity of 80%. It is tested in two populations, African Americans where the prevalence is 15% and Latin Americans where the prevalence is 0.5%. Which of the following is the most accurate statement? A. The sensitivity is increased in the African American population. B. The specificity is increased in the Latin American population. C. The positive predictive value is increased in the African American population. D. The negative predictive value is decreased in the Latin American population. E. The test is not reliable in the African American population. Well, one thing to remember is that the specificity and sensitivity is not relatable to the background prevalence of a particular disease. So they've told us that the specificity and sensitivity are 90 and 80% respectively. Those values are not influenced by the background prevalence of disease. Therefore, answer A and answer B would be incorrect because neither the sensitivity or specificity is altered by the different prevalences of this disease in these two populations. When you have a higher prevalence, as described earlier, this serves to increase the positive predictive value, and when you have a lower prevalence, this would serve to increase the negative predictive value. So in this case, we have a higher prevalence in African Americans, so there is a higher PPV for this population, and you have a lower prevalence in Latin Americans, so there would be a higher NPV in this population. The correct answer, therefore, is C. The positive predictive value is increased in the African American population, again because of the higher prevalence in this population. Now remember, when trying to think about these various equations, you can always place the truths on top. So for sensitivity, it's the true positives divided by the true positives and the false negatives. Specificity is the true negatives divided by the true negatives and the false positives. PPV is the true positives divided by all the positives. And NPV is the true negatives divided by all the negatives. The key here is to figure out which side row of the table you want to use. My advice is whenever given a test question involving sensitivity, specificity, PPV, or NPV is to redraw the 2x2 table for yourself. And if you feel comfortable using the disease state in the rows and the test result in the columns, or vice versa, redraw the table and however you feel comfortable drawing the table. This will provide the framework to answer all of these questions. Question. An experimental diagnostic test to non-invasively detect the presence of trisomy 21, which is Down syndrome, is administered to 500 pregnant women. The results are as follows. What is the sensitivity of the test? So here we have another 2x2 table with a disease state in the columns and the test result in the rows. We know that in order to compute sensitivity, it's simply a matter of looking at the true positives divided by all the people who have the disease. In this case, the true positives represents the number 100, or the upper left value, and the number of people who have the disease, or in this case the karyotype, is 200. Appropriate result here is going to be 0.5 or 50% sensitivity. One can also gather all sorts of other information simply by looking at the 2x2 table. For example, the prevalence. What is the prevalence of the disease? It's going to equal the total number of people who have a positive 21 karyotype divided by the total number of people who are karyotyped. Well, the number of people with a positive test is 200, and the number of people who were karyotyped altogether is going to be 500. That's 100 plus 100 plus 50 plus 250. That gives us a prevalence of 0.4. The positive predictive value is going to be the number of true positives, 100, divided by the total number of positives, which is 150. That's 100 plus 50, the top row. That gives us a PPV of 0.67. Similarly, the negative predictive value is the number of true negatives divided by all the negatives. The true negatives here is 250. There were a total of 350 people who had a negative test. Therefore, the NPV is 250 divided by 350, or 0.71. And finally, the specificity is looked at by going down the normal column, and that is 250 true negatives divided by all of the people who did not have this karyotype, which is 300, and that equals 0.83. It's a good habit whenever looking at a 2x2 table like this to immediately write down all these values so you have good practice in extracting values like sensitivity, specificity, PPV, NPV, and prevalence from this typical 2x2 table. Practice question. The following table summarizes the results of a new test to identify patients with acute myocardial infarction, and the data are shown as follows, with the disease state in the columns and the test result in the rows. If your patient has a positive test, what is the probability that he truly has acute MI? This is a test which is really asking you for the PPV. You're faced with a positive test. How predictive is it? Well, we know we can compute the PPV by looking at the true positives divided by all of the positives. In this case, that would be 120 divided by all of the positives, which is 120 plus 30, or 150. This gives us a PPV of 0.8. So the correct answer here is 0.8. Practice question. A certain disease has been shown to have a prevalence of 10% within a given population. If a screening test is developed that has a sensitivity of 80% and a specificity of 90%, what is the positive predictive value of the test? So here we're given a question that has the data in a different format than what we're used to seeing. They're giving us many of the extracted values like prevalence, PPV, and NPV. One thing you should recognize is when given these percentages, you can generate your own 2x2 table, and you can plug in any hypothetical total number of patients that you want. Well, let's do that. Let's make a 2x2 table, and we know already that the prevalence of a disease is 10%. Let's say we look at 10,000 patients. Well, if you look at 10,000 patients, we know that 1,000 of them will have the disease, and 9,000 of them will not. And we can use that at the bottom of each of these columns for disease. We can now fill in all the rest of these boxes based on what we know about the test sensitivity and specificity. If the sensitivity is 80%, we know that 800 of the people who really have the disease will test positive, and the other 200 will test negative, and that fills out the left-hand column. If the if the test has a specificity of 90%, we know that 90% of 9,000, or 8,100 of those people, will have a negative test, and therefore the other 900 will have a positive test. Now we have a fully filled out 2x2 table, and we can answer the more mundane question of what is the PPV. Well, we know already that the PPV is going to be the true positives, the top left value, divided by the total positives, all of the values in that top row. So that will be 800 divided by 1700 equals 0.47. I could have redone this question with any other total number. If I chose a total number of 100,000 people, I could fill in all these boxes and I should get the same value in the end. Practice question. A 36-year-old woman presents to her physician with joint pain, erythematous malar rash, and hematuria. The physician decides to perform an ANA test to look for autoimmune etiology. The test has a 75% sensitivity and 95% specificity. In the high-risk group, the PPV is 20% and the NPV is 93%. If the test is negative, what is the probability of SLE? Well, they've given us, again, the data in a slightly different format. We should take a look back in terms of how they've described the patient. The patient with joint pain, erythematous malar rash, and hematuria. And they've given us some information about what high-risk people's PPV and NPV are. High risk is another way of stating high prevalence. And given what we know about this patient and the manifestations of SLE, we would consider this patient to be in the high-risk group. So then for this particular patient, the PPV is 20%, and the NPV is 93%. So the test is negative. Well, given a negative test, the appropriate parameter to look at is the NPV. So given a negative test, what is the likelihood that this patient still has SLE? The answer here would be 7%, because the NPV is telling us the likelihood of this test being correct. Here they're asking us the likelihood that this test is incorrect, and therefore it will be 100 minus 93%. And the correct answer here is D, 7%. That concludes our discussion of applied statistics.